Recording has commenced. Well, good morning, everyone who's here and everyone who is rapidly joining. I am grateful for your presence. Today, welcome to the Oregon Bioethics and Humanities Colloquium presentation, Dementia Through a Lens of Relational Agency by our very own Dr. Eran Klein, MD, PhD. Please, everyone, mute yourselves at the end of the presentation. We'll have the opportunity for unmuting, putting our videos on, and doing some robust Q&A. So for those of you who don't know, the Oregon Bioethics and Humanities Colloquium is a 7-part endowed series that creates a space for thought-provoking discussion and exploration into complex bioethical issues that revolve around philosophy, the humanities, policy, and other cutting-edge research. Here at OBHC, we aim to create an environment that fosters critical examination of the human experience and seeks to provide new and innovative perspectives that will challenge everyone who attends. And I anticipate that we will be challenged today by this exciting talk. Speaking of our talk, it's my pleasure to introduce our speaker, Dr. Eran Klein. Dr. Klein is an associate professor in the Department of Neurology here at Oregon Health and Science University and a staff neurologist at the Portland Veterans Administration Healthcare System, and holds an affiliate appointment in the Department of Philosophy at the University of Washington. He co-led a neuroethics research lab at the University of Washington. He co-leads a neuroethics research lab at the University of Washington and is co-PI on multiple NIH neuroethics grants exploring ethical issues related to implantable neurotechnologies, like deep impacts on agency, like deep brain stimulation and brain-computer interface technology, and writes about neurotechnology and its impacts on agency, invasiveness, privacy, and trust. Drawing on work as a practicing cognitive neurologist, he writes about ethical issues in dementia care and research, including consent, the patient-clinician relationship, and dementia caregiving. Dr. Klein completed his medical school and a PhD in philosophy at Georgetown University under the mentorship of Edmund Pellegrino. He completed a residency in neurology and a fellowship in geriatric neurology at OBHC and the Portland VA, and was a Greenwall Fellow in Bioethics and Health Policy at Johns Hopkins University and Georgetown University. So without any further ado, Dr. Klein, take us away. Everyone mute yourselves, and we look forward to your talk.
Wonderful. Thank you, Tyler. Let me share. All right. Are we seeing that?
Yes.
Great. Thank you for that introduction. I'm really happy to be here today. I want to thank Tyler for creating the OBHC. I think it's so valuable for OHSU and Oregon to have this kind of dialogic space, both to sort of see what people here at OHSU and Oregon are doing and interested in, and to sort of touch the broader bioethics community. So I just kind of want to thank you and Dave and everybody at the center for kind of making this happen and bringing it to fruition. This is really a gift. So what I want to do today is talk a little bit about dementia, really Alzheimer's mostly. And what I'm going to do today kind of falls somewhere in the middle of kind of personal reflection, bioethics survey, philosophical argument. So I want to thank you in advance for kind of hanging with me through this. All right, but to start off, I think it's important to sort of acknowledge my particular positionality and the limits of that. So I'm a clinician who specializes in treating people with dementia. I talk to a lot of people about memory, reasoning, day-to-day functioning, people who think they have problems, people who think they don't, family members who think their loved ones have problems, and some who think they don't. But I'm always standing on that doctor side of these conversations. So, I want to acknowledge sort of right off that, I don't presume to really know what it's like to live with dementia, from the inside, as it were. I mean, what I've gleaned over the years about dementia is mostly the result of these stories that hundreds of patients and families have shared with me. So So even to be here today, I owe them a great deal of gratitude, and I want to apologize in advance for whatever I get wrong in that regard. And then I'm also grateful to my many colleagues, some of whom are here today, who I've learned from, including those who've acquiesced to my picture taking, as Dr. Goodland did here, simulating a patient with dementia. All right. So I'm going to start off with a case study published by a group led by Ingrid Hellstrom a few years back. They present the case of a couple, the Svensons, and analyze how the couple talks about dementia, how dementia changed their lives. The case is sort of the impetus for today's talk. So let me give a few brief facts about it. So this is a couple that sort of married late in life. They sort of met in the church choir. The church is really important to them. She was a missionary for many years. I think this is his second marriage. She sort of sees her most important work, at this stage, as being her kind of regular contribution to this kind of local church radio program she does. And they describe themselves, right, in this series of interviews as having a really close and loving relationship. But then she's given this diagnosis of Alzheimer's disease, and while that was difficult to hear and absorb, they both sort of talk about how lucky they are to have found each other, prior to the diagnosis, and how they both sort of adjusted their relationship over time, and both kind of talking about how they value their relationship through this diagnosis. And the authors sort of sprinkle, some of their interviews with the couple throughout their paper, and I want to share a few of those. One of these is this discussion about finances. So she's developed problems with money management, though she doesn't really recognize the problems or necessarily his help of her in that regard. He notes that he kind of keeps track of their finances and travels with her to the bank and sort of subtly reminds her of her PIN when she's withdrawing money. But it's obvious in the way that he contributes to this discussion that he often helps her in ways that he doesn't really make a big deal out of his help, and maybe in ways that aren't noticed by her or others. The couple also talks about her love and pride in baking. And again, she doesn't think she has difficulty with this, but her husband has begun to, keep her wife company in the kitchen and sort of, gently encourages her to kind of talk out her recipes out loud. And the final example here, they talk about her continuing to participate in this church radio program, which is, as I said, really kind of important to her sense of self. And they talk about him accompanying her to the program and his sort of gently prompting her, when she gets stuck. So I remember reading this story and really liking it, but also feeling a little unsettled by it, actually. My initial thought was that it paints a little bit of a rosy picture of dementia, what it's like for couples to go through this experience. Part of me thought, this isn't what dementia is really like, right? This is a sort of a feel-good story, and that has value, for sure. But it's the exception, not the rule. And insofar as this kind of narrative distracts from what dementia is really like, indulging in this kind of story might actually be at times harmful or kind of counterproductive to solving some of the ethical problems that arise in dementia. So I sort of put this story out of mind, but like any kind of good piece of writing, my thoughts sort of kept returning to it. So I remember a few weeks later, I was talking to this older man and his wife during a follow-up visit for his moderate advanced dementia. And as I usually do, I asked him, actually her mostly, right, about his ability to shower on his own. I asked her, has he lost the ability to shower on his own? Have you taken this over for him? And I remember she sort of shrugged, smiled a little sheepishly and said, I'm not really sure, for a while now, we've just showered together. Um, and I think it was at this point that the Svensson story sort of flooded back to me. Um, the story is about dementia, about living with dementia, but I think the thing I couldn't quite square was that it isn't a story framed in terms of loss, right? It's a story about sharing, about kind of doing things together in the midst of dementia, and it's this feature that's sort of foregrounded, not because it paints a rosy picture of dementia, but because it kind of focuses our attention on what's happening in dementia in a different way, right? Really at the level of the relationship itself. But this isn't the way we talk about dementia, right? I mean, we talk about dementia, we conceptualize dementia largely as a form of or forms of loss, right? The language of loss is kind of pervasive in how we talk about dementia. So I wanted to give a few examples, many of which are or might seem obvious. When we talk about dementia, we talk about how people living with dementia lose things, right? They lose where they park their car, they lose their keys, they lose their place in whatever they were reading or watching or conversing about, right? They lose abilities, right? To work, to drive, to manage their finances, to cook for themselves. They lose their ability to learn to use or to learn to use technology, and given our increasing reliance on technology to function in the modern world, this loss of technological skills is often profoundly felt. Losing access to entertainment, to communication, and even the kind of mundane daily joys. And sometimes as a result of or as a way to compensate for these many losses, people with dementia lose freedoms, right? Previously taken for granted, right? Cameras in the home that are monitored by concerned family, financial and healthcare decisions delegated to family or others, and living spaces that become shared with strangers, right? All are ways of enhancing safety, but they result in losses of privacy for sure. And all of these kinds of losses are what clinicians like me inquire about when patients and families sit down with me in the clinic. And the language of loss is as much a part of how medicine conceptualizes dementia as it is a part of the home life of people living with dementia, right? The textbooks we learn from and guide practice, right, are not subtle about the relationship of dementia and loss. And this loss is infused throughout the clinic visits that I have with patients and families, right? The loss that patients are experiencing is kind of relentlessly documented and trended, right? With cognitive screening tools like the MoCA here or the mini mental status exam, right? Which start at 30 points, and with nearly every visit, right? I have to inform them, they perform it, and then I have to inform them that they've lost points, right? Their score inevitably sort of marching down, sort of this very concrete experience of loss. And the same is true for instruments that I and others use to measure the range of loss of daily functioning. And the losses aren't just made evident by the cognitive tests and list of daily functions, but the loss is seen, right, in the images of the brain, right? The hippocampus and other critical structures, so they shrink, right? Over time they atrophy, and we talk about this as brain loss, and it's just this concrete pictorial representation of progressive loss. So it's clear that the message that patients and families get from medicine about dementia is loud and clear, right? Dementia is fundamentally about loss, right? And this loss is reinforced through patient education, right? As can be seen here, right? There's a fact sheet about dementia from the NIH and sort of the sort of patient-facing Alzheimer's disease webpage, right? Both frame dementia in terms of loss. Right, and when families, go and sort of search for education to sort of better understand what they're experiencing, they encounter the same, right? These are top sellers on Amazon. And I promise this is the last one. The language of loss is not confined to the experience of the person living with dementia, but also used to describe, what's happening to loved ones, right? As this sort of qualitative study highlights, right? The couple, in this case, spouses, right, lose things as well, right? The themes that the authors in this study point out are that couples lose a shared um, a shared past that they can reminisce on. They lose shared meaningful day-to-day activities. They lose envisioning their future together. Right. So admittedly, much of this loss is metaphorical. We don't, literally lose memories or functions. They don't, drop out of our pockets or get inadvertently left on a table, right? But even if it is only a metaphor, right, it's striking to me how ubiquitous this is. I mean, metaphors, sometimes can be so pervasive that they shape how we experience the world. And so I think that the grip of the loss metaphor can really be seen when we turn to see how people in bioethics talk about dementia. So 30 years ago, Ronald Dworkin and Rebecca Dresser engaged in this spirited debate about advanced directives in the setting of individuals with dementia. And I know that some people here, I think Sam Muramoto has written some about this. In his book, Dworkin argues that people have both experiential interests and critical interests, right? So experiential interests are things like playing softball, cooking, eating well, watching Casablanca, walking in the woods, those sorts of things. And critical interests, on the other hand, are these sort of central roles and projects around which we build a meaningful life, like jobs, relationships, passions. And what he argues is that people with dementia, late stage specifically, sort of lack sufficient autonomy to have critical interests anymore. So when it comes to deciding on end of life treatment, right, when a person had made an advance directive earlier in life, we should respect the person's precedent autonomy, right? The autonomy they used to have, right? The autonomy that was operative when they had critical interests. So what they said they would want at that time, right, should be what is followed now. Rebecca Dresser has sort of famously critiqued Dworkin's view, challenging his notion of precedent autonomy. She argues that you can't compare the person before dementia to the person with advanced dementia. They are kind of, in a sense, different people. And as such, we need to take the person in front of us, right? The person with an advanced directive, what they want, and even if this contradicts what their earlier self would have wanted, we have to take the person in front of us seriously, and generally as sort of overriding of previous wishes. And I think the thing that's interesting to me about, well, one of the things that's interesting to me about kind of both sides of this debate and many others who've sort of continued this debate in one way or another over the years, is the again, the centrality of loss, right? You sort of see that that language throughout arguments on the many sides, right? that seems to be what matters, right? It might be a loss of interests or a loss of autonomy or a loss of ability to value or a loss of self. But kind of what isn't in question seems to be that the phenomenon of interest is loss. Now, there are some narratives out there that sort of push back against this. The medical anthropologist Janelle Taylor, for instance, in writing about her relationship with her mother, talks poignantly about how the language of loss can be distracting and sometimes obscures the important ways in which the disease shifts interests and relationships in unexpected and sometimes welcome ways. Right. So she writes, those who have little firsthand experience with dementia tend, I think, to imagine it as a more or less purely cognitive loss of a store of remembered facts manifested in the loss of the ability to recite names and dates and other bits of information. But she contends that the experience of their dyad traveling together, right, her and her mother, through dementia is so much more than loss, right? She gives this example of how kind of visiting her mother forces her to step away from the kind of complex, kind of linear oriented hustle and bustle of her life and step into her mother's world, right? To sort of slow down, live and appreciate the moment with her mom, right? To people watch, for instance, right? And this just isn't about loss. So as an aside, I would recommend that the most recent episode of This American Life has Janelle Taylor reciting some of her book. So if we think back to the Svensons, right, the authors conclude by talking not about autonomy or identity, but about agency, right? So agency is this, capacity for or the exercise of the ability to act, right, or refrain from acting, right? So it's not so much about deciding which of my options best fit with who I take myself to be, which we might understand as, autonomy and identity and kind of how they're connected, but how do I effectively do the thing that I want to do, right? So how do people living with dementia experience changes in their agency? Well, they increasingly have problems enacting their will on the world. So, right, they start to fail in various ways, right? Why didn't the remote control change the TV channels I intended, right? Why did I get turned around on the drive home back from the store? Why didn't anyone laugh at the entertaining anecdote I told, right? These events are experienced by the person living with dementia as a kind of mismatch of their intended action and their expected outcome. And sometimes people with dementia sort of will rationalize or reinterpret what happened, right? The remote control was must be broken, or the traffic was distracting. The crowd lacks a sense of humor, right? Or at other times, unfortunately, but understandably, people living with dementia lash out and blame others, right? Family member, which is something that family members can be all too familiar with. I think often because of these misfirings of agency, they're in people with dementia, they're not necessarily remembered from one to the next, right? Because of the short-term memory problems. And so the person living with dementia doesn't necessarily experience this as sort of a recurring problem of their agency. What they feel in the moment is just that their agency is being thwarted. Oh, and so, so there's a way, I think, in which what happens in dementia can be explained as a progressive loss of agency. Like, I don't think it doesn't make sense to use that language. And I think this is how it's often talked about, right? People lose autonomy, they lose identity, and eventually they lose agency, right? I think this focus on loss shapes not just debates about advanced directives, right, as we've seen, but a multitude of other ethical issues that come up in the context of dementia. right? So loss of agency in people living with dementia sort of leads family and caregivers to their response is to sort of substitute their agency, right? They substitute their agency by stepping in to pay bills, take over driving, give medications, right, and the like. And to be an effective substitute, family needs to learn how to surveil, right, their loved ones for hints of confirmatory evidence of failing agency, right? Surveillance becomes kind of an important part of of how the family comes to know when it's time to step in and take over. And you know, in this sort of paradigm, right, the issues that remain are figuring out like what are the threshold levels for triggering intervention, right? For obtaining a driver's evaluation, or setting up assisted living arrangements, or getting a financial fiduciary, and putting together an advance directive. And second, you know, and also sort of figuring out whose agency is legitimate, is a legitimate substitute, right? And sort of deciding on that. Okay. So, but I think this way of thinking about agency and substitution as the appropriate response to changes in agency is, I think this is owed in large part to a particular way of thinking about autonomy that functions in the background of much of bioethics, right? You know, as I think we're all aware, right, the concept of autonomy has been central to Western bioethics since its beginnings, right? The respect for autonomy, you know, is one of Beecham and Childress's, you know, core principles. It's at the heart of respect for persons. That's part of the Belmont principles for research ethics. And while there's been a lot of argument about autonomy's sort of seeming pride of place in bioethics, or at least particularly the American version of that, since the early 70s, it's only been in the last few decades that theorists, you know, particularly coming out of the feminist tradition, have called into question kind of the how we talk about autonomy itself. So, right, in a nutshell, the critique is that bioethics, you know, following the traditions of Kant and Mill and others, has operated under a particularly individualistic conception of autonomy, right? The view of autonomy, this view of autonomy is really concerned with sort of self-rule, where the ideal decision maker or patient, as the quote here from Susan Sherman states, is that this sort of solitary, rational, free agent, sort of unencumbered by relationships to or the influence of others. So, you know, when we want to know what to do in bioethics, this is the ideal that we're sort of enjoined to envision. So in place of this view of autonomy, you know, some have offered theories of relational autonomy, where relational autonomy is, you know, a cluster of approaches to autonomy, which sort of emphasize rather than sort of ignore the socially embedded nature of individuals, right? It's the idea that individuals are at heart social beings, right? Whose identities, you know, are not are not really even understandable outside of their social relationships, right? So, in a nutshell, independence and vulnerabilities, right? They're not aberrations, right? They are, you know, from birth to death, you know, part and parcel of being human, right? We don't live a good life, right, despite our dependencies and vulnerabilities, but because of them. So if we, you know, if we sort of try to adopt a more relationalist lens, you know, what does that mean for agency and dementia? Well, you know, we could take the phenomenon of memory, right, which is often, right, central to the experience of dementia. Right, a relational approach might call into question whether the cognitive processes that are sort of paradigmatically individualistic or portrayed as such? Memory formation, retention, access. Are they, in fact, sort of misunderstood in that way, right? I mean, if you think about it, remembering is often not purely individual, right? It's often shared in one way or another, right? We use memory aids, right? As one of my patients proudly showed off. We use Google to answer our trivia or get around, right? Some philosophers take this idea even further and advocate for an extended mind, arguing that our cognition actually extends into the world, into these objects. But we don't have to go that far to sort of acknowledge that we rely on others, right? As it were, as part of our remembering, right? Silver and Francis refer to this as being a cognitive prosthetic for others, right? And there are particular ways, examples of memory being collaborative. So Celia Harris talks about collaborative memory when, for instance, kind of one member of a couple is a specialist in remembering birthdays and special events, and the other is remembers which bills have to be paid, right? So this kind of division of labor. And there's a version of this kind of collaboration that clearly happens in dementia as well. I think I see this most often in what I sort of feel is this, or what I think of as this sort of rescue me look, right? When I'm taking a cognitive history, I ask questions. What did you do yesterday? Tell me something you've seen in the news recently, right? And the person's eyes, right, immediately dart to their loved one. And I know when I see this, that this is far from the first time that this has happened, right? That really what I'm witnessing in that moment is sort of a well-worn pattern, right, between these two individuals, right? It's this way of interacting where this reliance has become kind of a groove that they fall into, right? It's born of countless times of doing this before in a million different contexts. Sometimes the family member, in fact, will finish, will step in and answer that question sort of out of habit, without a pause. Sometimes catching themselves, realizing that the clinical visit is meant to sort of break out of that groove and sort of show the kind of naked truth of their loved one. And then, at other times, right, the loved one does sort of withhold. And this can lead to kind of a pain on both of their faces, right? Evincing almost a kind of betrayal, right? With this look, that it's like, this is how we work, right? Right? Why are you staying silent, right? And it's this kind of the degree of discombobulation that I see it is a kind of tell, right? It helps me in my diagnosis, even though it's also painful for me to watch. And couples living with dementia collaborate in other ways than just remembering, right? So people who have difficulty with language because of their dementia, they learn to communicate in other ways. They use gestures or rely on yes/no questions to kind of progressively narrow a topic. And whatever the strategy, the couples end up leaning on kind of their shared history, right? Certain words or phrases mean something based on this history. And sometimes people get so good at this that I struggle to keep up, right? It's as if they sort of are anticipating steps ahead in their conversation. And then we can also see this in sort of visual spatial skills, right? Or navigation, right? Where one member of the couple without dementia sort of rides in the passenger side of the car and sort of co-pilots, right? Providing, not just directions, but kind of warning about hazards, keeping the person focused on the road, limiting distractions, calming or de-escalating. Note, I'm not advocating for people with dementia uh, driving, but just to note that that is. I also acknowledge that that is something that that happens particularly early in the disease. But I think, one of the things that's interesting about thinking about kind of shared relational agency in dementia is that I think it can prompt us to think about the ways that people without dementia share agency in their everyday lives, right? And so I wonder whether or not, maybe we come to or are taught to, overlook or undervalue this. And that sharing agency in dementia is just sort of an extension of forms of agency that couples engage in at other stages of their lives. So I think it's worth keeping in mind with shared agency that this can bring new responsibilities, right? So take remembering significant life events, right? People with dementia forget about divorces or deaths or other painful events, and will repeatedly inquire about them. And this often presents a dilemma for the partner, right? Whether to tell the truth and subject their loved one to kind of a re-traumatization, learning anew again and again about a painful event, or instead to engage in a kind of paternalistic deception, right? And it's undoubtedly the case when we share agency, we often make ourselves vulnerable, right? We entrust someone else with enacting our will on the world, and I think that's why deception in these cases can feel like a betrayal, right? But sharing agency is more than just about the individual speech act, right? It's about sharing agency with respect to everything that makes that speech act meaningful, right? So, like here, I really like Matilda Carter's recent papers where she advocates for giving moral weight to what she calls the parallel subjectivity of people living with dementia, which in part out of considerations of justice, sort of calls us to pay attention to sort of the underlying needs that prompt a person with dementia to ask about a potentially re-traumatizing subject. So, for example, she gives this example of a man asking about the whereabouts of his dead husband when he's out in an unfamiliar location. And her response is that this can be that there can be a kind of ethical deception by omission in this case, where distraction may be appropriate and without sort of answering the question directly. If what you're recognizing is that it's this that what's motivating this question is a sense of being scared. And being in an unfamiliar place. And so maybe then the response is to take the man home, sit and take a break with him, offer reassurance that he's safe, right? So there's this so sharing agency may be taking responsibility not just for telling the truth or not telling the truth, but for attending to why the question was asked in the first place. So what I want to do now is shift a little bit to envision what it might mean to take seriously that shared relational agency in dementia. So one implication of taking shared relational agency seriously is that it might prompt us to shift how caregivers are understood, treated, and supported. So in particular, it might call attention to who is expected to share agency and how. So you'll notice some similarity across the three. These are the top three Google search results that came up for me under the term dementia caregiver, right? So there's certain gendered components to our conception of agency and what's an appropriate way to share agency. Another implication is for treatment, right? So one of the challenges in developing treatments for dementia is deciding on what counts as success, right? So is it scoring points on a cognitive test? Is it maintaining particular activities or daily functionings? Is it the ability to continue living at home, right? One might argue that the metrics of success that we currently work with are principally concerned with advancing that individualist autonomy ideal, right, that was critiqued earlier, right? And so the natural inference from our current metrics of success for a lot of dementia treatments is that the goal of dementia might be to allow people to share agency less, right? So I think taking a shared relational agency seriously is also according it a kind of value, and that we need to find ways to incorporate that value into how we judge these different therapies. So the new monoclonal antibodies that have gained a lot of attention for treatment of Alzheimer's disease recently are really demanding, right? So these are going to require that people go to an infusion center every 2 weeks, that they get 4 or 5 or more MRIs every year, or at least in the first year, and that their loved ones monitor their behavior on a day-to-day basis for any sign of development of brain bleeding or brain edema, right? So maybe taking the shared agency seriously means thinking about how these treatments may affect the relationship, not just the person with dementia. Another area that we might think about is home health monitoring, right? So cameras and other monitoring devices are increasingly used to monitor people with dementia. Many people use these and find them, beneficial, right? Allowing people with dementia to continue to live in their home and allow family members to monitor from a distance, provide care from a distance. But as Anita Ho has recently written, these technologies are not without significant costs, and the decisions about them really ought to be understood against kind of a background of our fragmented healthcare system, poor social safety net, and the unjust and often gendered expectations of caregiving. I mean, she really makes a compelling case for why these technologies, if not implemented carefully, have the potential to increase stigma about dependence and aging, moralize the use of monitoring, medicalize the home, and create kind of new caregiving responsibilities. And so taking shared relational agency seriously might mean having more frank discussions about how these technologies are going to affect the relationship. And for more on this, I would call people's attention to Lindsay Miller and colleagues at OHSU who've done some and are doing some really interesting work on this topic. And so finally, shared relational agency, taking this seriously, right, can have practical implications for how societies, right, structure the environment around people living with dementias. So, many of our hospitals and public spaces are not dementia friendly, right? These are spaces, right, filled with complicated signage, help desks and kiosks that are difficult to access, distracting sights and sounds, right, which loud overhead music, flashing lights, video displays, right, that can disproportionately negatively affect individuals with dementia. And anecdotally, I can say that I see this often on the haggard faces of patients and families as they make their way into the clinic, like to see me, right? Just getting to the appointment can be an accomplishment. So taking seriously relational agency might mean attending to agency in these public spaces, right? So maybe that means designing spaces that um, allow for lines that have two people astride, or that provide private spaces for filling out sensitive forms and that sort of thing. So a couple things are worth noting before I conclude. So, of course, not all relationships in the context of dementia are healthy, right? Family members can take over unnecessarily or prematurely, right? Robbing the person with the diagnosis of the opportunity to contribute to their own shared agency, or their part of that shared agency. Um, and this can take different forms, right? Dominating conversations, or taking over activities like handing out medications when kind of simple reminding might do, or excluding from decision making. For example, taking over financial planning when kind of bill paying assistance might suffice. But acknowledging that relationships can be at times unhealthy, even if well intentioned, doesn't take away from the value and importance of sharing agency well. Second, shared agency should not be overvalued, right? I think dementia is difficult and harmful in so many ways. And, which is why I think it's all the more important in talking about the good that can come from sharing agency, to not let this, I don't know, fall in with kind of callous or even kind of patronizing ways of talking, right? Dementia allows you to get closer to your loved one, or it teaches you to be a better person or husband or wife or child, right? I think that sharing agency can be rewarding or fulfilling or enlightening at times, right? Just as it can be so in relationships not affected by dementia. Should not overshadow or diminish what people are living with dementia and their families are enduring now. Um, and finally, I don't mean to imply that it's a mistake or does not make sense to talk about loss in dementia, even loss of agency. Dementia can be viewed through a lens of loss, and loss language can have some significant pragmatic utility for sure. I think my point here is more that to highlight the power of that loss language, the power it has to sort of crowd out and lead to an undervaluing of certain experiences, particularly around sharing agency that happen between family and caregivers. So with that, I'll end and thank mostly my research group at the University of Washington, Sarah Gehring, who I've talked over these issues with many times.
Thanks, Eran. Man, that was really good. That is very provoking. Um, and while people gather their thoughts and questions, I'll ask a thought and question, or I'll give a thought and ask a question. I guess my first, I have two questions. Um, the idea of, if I have dementia and I know that at every visit I'm going to be sort of mercilessly graded on a test that is certainly going to show that I am inexorably declining in my ability to know myself and know things, seems cruel, actually. And so my first question is, yeah, do you think that, given everything you've said, that whole grading process could be or should be changed, or is there really a utility other than the sort of deep desire we in medicine have to know everything and mark everything and grade everything?
Yeah, so I think there is value in doing that testing, because I do think that it helps when new things come up, when people have problems um, with their functioning that require some sort of intervention. I do think it's helpful for the clinician and sometimes the family and sometimes the person themselves um, to know sort of where they are. what things that they struggle with and what things they're strong in. I think um, I think I think what I don't do and what maybe we should do is talk to people at the beginning of the process about kind of how they would like their, they're going to come in multiple times over the, over several years. How would you like information given back to you? And we can do this test and I can tell you what the results or we can just do the test and um, and we can and you can ask about wanting that if you happen to want it at a particular time. So I don't think we sort of give people the opportunities to sort of shape their experience of clinical care in that way. And I think that would be an interesting thing to think about.
Mm. Allison Lindauer, feel free to unmute and ask your question. I see your hand.
Hi, yeah, thank you. Thank you so much, Erin. I really, really appreciate this very valuable presentation. And just a couple comments. I really liked your comment on loss. I think that the conversation around loss is really what undergirds that therapeutic nihilism that leads to underdiagnosis in dementia care. And so this like, well, I'm not going to tell them they have dementia because what good is it going to do? I can't do anything and it's just going to ruin their lives. And I see Nirmala Dar's on the talk, and really the great value that I try to tell my colleagues is there's a real value in knowing a diagnosis. There's so much, I mean, it gives a person power and it gives a family a chance to make changes or engage in research. And so just inserting that idea of the what loss means and naming it, and maybe we can tame it. I really, really appreciate that. The other term I hear, and all of you can laugh at me because you always do, I hate the word loved one. It adds so much meaning to a relationship that may or may not be there. And so when I meet a family, I work with families with dementia all the time, and I really try to avoid the word love because I don't know if love is there. And if it isn't, how are we going to negotiate this complicated path? And then finally, to your point, Dr. Tate, I work mostly with people with moderate to advanced dementia. So when I sit down with them, I'll ask them, do you want a memory assessment today? Because it's not going to change my medications. It's not really going to change my therapy. And that gives them, again, that sense of agency of like, not today, maybe next time. And sometimes the families will want that, and then we'll have a conversation around it. But those are just my comments. Thank you so much, Erin. And thank you also for all your wonderful support for our research. It means so much to me.
Thank you, Allison. I echo everything you just said.
Well, other folks, there's some great conversation about the sort of implicit sense of personhood that comes in the West from I think, therefore I am. I'll riff on that and just ask, while other people gather questions, Eran. So I'm super struck by this, the kind of individualistic autonomy oriented way in bioethics we think about things. I mean, I've written about this, you've helped me write about this. And it reminded me of in pediatrics, we have the ages and stages. We are constantly grading children and their development. And there's been a lot of criticism of the way that pediatrics idealizes the, perfectly developing child who ultimately is going to become a working adult. There's sort of like the capitalistic, the kind of a Marxist critique of that, but you don't need to go there. You can just see a neuroatypical child, the child with autism who is not fitting into this rubric, really can struggle with that kind of medicalized gaze. So I'm wondering, in other countries that perhaps don't have the same history as the United States, are there differences? Do those differences in sort of ethos and culture manifest in differences in care for people with dementia? I've heard about, I think in France or Switzerland, they were developing these like nature homes for people, like these dementia care centers that were out like on farms. And what they actually found was that people are having more anxiety because they're not used to living on farms and in nature. And so there's like an interesting ways that, our cultural expectations impact the structures we build. So I just was wondering if if there's kind of cross-cultural or differences in how we think about dementia.
Yeah, I think, yeah, I think so I am not an expert in this, but I did show there's on the slide talking about deception, right? That was this pretend bus stop that is put outside of a memory care center in I think that was in Germany. And I think there is there the idea that of being dementia friendly, I think is perhaps a little bit more advanced in certain parts of Western Europe, at least, where I think it's so there are where it's less of where there are these sort of dementia villages that get that get built to sort of help people to allow people if they and their family want to sort of live in a less anxiety provoking and more familiar sort of environment. And I think that those things sort of strike, I think, Americans as just sort of too deceptive to be and in some way a kind of violation. But I think so I think there's some a different kind of ethos, at least in some parts of Europe than in the U.S.
Thank you. And Nirmala sort of had a similar question. Mia Krupper, I'm not sure, how does this impact the progression that's Alzheimer's disease? I'm not quite sure I understand the question. If you're on,
I, it was a typo. It was intended to be two. More curious, this is the sort of the early stages of dementia is how I'm hearing this talk being delivered. And I'm curious about the progression to diagnosis for early onset dementia and for the or early onset Alzheimer's, and then the progression into full-blown Alzheimer's. At what point do these tools transition as that progression is moving forward? How do we bring in this autonomy and this advocacy as things are moving forward? I'm a general practitioner, and so I'm more thinking about how to support patients who are developing this and the dialogue that they're having with their specialist in neurology moving forward, and things to think about or have on their list to be discussing. And at what point do we modify the decisions that have been made in the past when it was viewed as more a dementia status as we're moving into more an Alzheimer's disease diagnosis?
Yeah, thank you. I think there's a lot in there. I mean, I do think that that the sharing of agency is certainly going to be reflected differently early in the disease versus later in the disease, and kind of what we mean by this, that sharing is going to be more asymmetric, obviously, later in the disease. I think one of the maybe more controversial aspects of sort of taking the sort of shared agency seriously is that it may mean that we include we include family as decision makers to give consent for things that right now we in our sort of Western legal notions of autonomy don't countenance. And so there's something a little bit transgressive in really taking the idea that the relationship really matters at sort of an ontological level and ethical level. It really matters, and that and so giving value to that sometimes over the individual, the person with the disease, you know, conceived in some separate sense, is, I think, maybe hard for people to swallow, actually.
Well, thank you, Eran. Josephine, I see other questions. Unfortunately, I have to be off because I'm on clinical service and have to go round. However, Dave, if you want to put your email in the chat, people can please email Dave and he can connect you with Dr. Klein. And Dave, if you would also copy the comments and send them to Dr. Klein as well, to continue the conversation to the extent desired and possible. And just to comment on Dr. Taub's comment, I think all of us, I hope, we know that there is a real need to measure things because that helps us trigger services, which is the same in pediatrics and dementia care, I imagine. I think the important note is that there's ways to do it wisely and compassionately that don't make us all feel like we're just putting people up against the ruler. But thank you, Dr. Klein. That was fantastic. I think we'll all have a lot of thoughts to take away from this. I will remark that, let me find my next next OBHC will be Friday, May 10th. We're having a break because we have the Kinsman Conference, which Dave has put some information in the chat about in April. And on Friday, May 10th, however, Kevin Dirksen from Providence Center for Healthcare Ethics will talk to us about Justice Rising, a moral imagination for a more trustworthy bioethics. And a flyer with a link to that talk will be sent out to everyone on our mailing list soon. Please email Dave Hoyt if you would like to be added to that mailing list and you're not already a part of it. Thank you again, Dr. Klein. Thank you, everyone, for joining us, and I hope that this conversation continues.